Hello viewers, here I am. I'm Dr. Naveen Narendranath, a consultant ophthalmologist here in Chennai. So today I'm going to talk about a topic that is very close to my heart. It's something that I'm really passionate about. Today this topic is what we call retinopathy of prematurity. So by this, we are talking about a disease which affects the retina of preterm babies. Now before I go into this topic, I would like to explain to you what a preterm baby is, and then I'll go into the topic. So normally when we expect a pregnancy to last the full duration, we expect it to last anywhere between 38 to 40 weeks. Sometimes what happens, for various unknown reasons, the mother goes in for preterm labor. Now this preterm labor may be anywhere between 24 to 36 weeks. So then they give birth to what we call preterm babies. Now these preterm babies are extremely small. Their birth weights can vary anywhere from minimum of even 450 to 500 grams. Can you imagine? Normally we talk about babies weighing 2.5, 3 kilos, 3.5 kilos, but these babies weigh just about half a kilo. Now why the eyes take precedence here is because the eyes are a very complex structure and they take the longest to develop. In fact, the development continues well after birth even up to the age of 8 to 10, where the neural pathways continue to keep developing and becoming more mature. So because the eye is so complex, when we examine a preterm baby's eye, there are so many things that we look out for, especially for this condition called retinopathy of prematurity. So ROP in short is a potentially devastating condition which can cause blindness in these preterm babies. It can cause gross visual loss for these small babies. So I take it on myself to go and do what we call ROP screening. So all babies born less than 34 or 36 weeks undergo this screening, where I go and I examine these babies' eyes and I look for whether the child has ROP or not. So many times kids may have not just retinopathy of prematurity, they may have various other eye problems as well. Problems like congenital defects, where certain parts of the eye do not develop adequately. Sometimes they can have even tumors inside the eye. Sometimes they can have inflammation or scarring within the eye. Sometimes they can have other problems like cataract. So this all comes under the purview of what we call universal eye screening. So I am really passionate about this ROP screening or universal eye screening because I get to treat many of these really tiny babies, and it gives me a lot of, I feel privileged really when I look at these babies. So for this disease, there are, like any other disease, like let us say diabetes or hypertension, there are many risk factors associated with this disease. So firstly, I would like to classify this as risk factors associated with the mother and risk factors associated with the baby. So for example, the mother may have diabetes, may have hypertension during the pregnancy, may have some thyroid issues during pregnancy, and most importantly could also have what we call abnormal Doppler changes. See, the mother and the baby, they are connected together through the umbilical cord. So the blood supply through the cord has to be adequate, and if that is inadequate, that can lead to a lot of other problems. The baby may not get adequate nutrition, baby may not grow properly, so on and so forth. So even abnormal Doppler is a very important maternal risk factor. The same way, we have many factors associated with the baby. I think the most important factor is low birth weight. So as I mentioned earlier, sometimes these babies are so small, they would weigh just 500 grams. And let me tell you, this 500 grams, the babies can just be held within the palm of your hand, they are like so small. And these poor babies, they are connected to so many tubes, they need oxygen to survive, they need the right temperature maintenance, humidity. It's really a very complex environment that they need to grow up in. And within this complex environment, I will have to gently, without disturbing the environment, have to examine their eyes. So, there is a lot of technical things that also go on behind the scenes. Another very important factor, a neonatal risk factor, is the maturity of the child's respiratory system or their breathing apparatus, because these babies need special chemicals called surfactant to help release and open up the lungs. And then they are connected to a mechanical ventilator, or they need high pressure oxygen under high flow. Only then the child gets enough oxygen delivered to all parts of the body. So, when a child has a very immature breathing apparatus, naturally their eyes also tend to be very weak. Naturally they have a very high chance of developing ROP. Similarly, babies who have received surfactant treatment, who have been under ventilator for a long period of time, who have received CPAP ventilation for a long period of time, or on high flow nasal oxygen for a long period of time, all these babies are at a very high risk of developing ROP. Besides this, there are many other risk factors, like for example multiple birth. So, if we see twins or triplets, which is something that which used to be quite rare those days, but nowadays I see a lot of twins and even triplets. So, that is a fun thing, and even that is a risk factor, because when you have multiple gestations, that is multiple babies, these babies tend to be smaller, and because of that they can be more immature. Besides this, there are many other factors like sepsis, like intestinal obstruction or intestinal infection. They can have other breathing problems that we call apnea, where they suddenly stop breathing for some reason, they just stop breathing. They may also have a very low hemoglobin levels in their blood, and they may need even blood transfusion. So, when we have history of blood transfusion, this is again a major risk factor for development of ROP. Now, ROP, just like any other involvement of any other system, the same way the eye also requires sometimes special interventions. So, when we go and do ROP screening, many people think that we just use a torchlight or something to look at the eye. No, in fact, for ROP screening, these babies have to be dilated by special drops. So, the pupil of the eye is actually dilated with the help of these drops well before I arrive on the scene, and this will help me to look at the inner aspect of the eye. Remember, the retina is not something that is easily visualized, it is something that is present on the inner aspect of the eye, and to do a thorough examination we need to dilate the pupils properly, because that is the gateway that sort of allows the light to go into the eye. So, when that is widened, it enables me to see all those structures a lot more clearly. So, when I look into the eye, I look at various structures, whether they are developed properly or not. I look at the optic disc, the macular area, and most importantly the blood vessel growth. Now, very often what happens is, for these preterm babies, these blood vessels do not reach up to the very end. They are actually supposed to reach up to the very end, but they do not. So, you have areas that we call avascular areas, and this basically refers to areas where there are no blood supply at all. It is just pure retina, there are no blood vessels. Now, we know that for any part of the body we need a healthy blood supply, only then that part will function properly. So, what happens here is that these blood vessels slowly but steadily they start to develop. So, I keep looking at these babies once every week, once every 2 weeks, and I will assess and see if these blood vessels are in fact growing or not. So, just to have some sort of an idea as to how much the blood vessels are growing, in general babies' eyes we typically divide them into 3 zones. So, zone 1 basically means very little bit of the retina is developed, the blood vessels are developed. Zone 2, which covers anywhere between 30 to 70%, and zone 3, which covers the remaining 20-30%. So, when we have blood vessels extending only into zone 1, it means the baby is very small, it means the blood vessels have not developed properly. If it is in zone 2, we can breathe a little easily. These babies typically tend to do well, and these blood vessels slowly tend to develop into zone 3 and then it becomes completely mature. But sometimes that does not happen. In 15 to 20% of the cases, these blood vessels, for some reason, they do not develop adequately, they do not develop properly. So, what happens here is that the blood vessels, instead of growing in a horizontal manner, they sometimes take off like a plane, they start growing vertically. Now, this is dangerous. Now, this is precisely what we call retinopathy of prematurity, because what happens here is that these abnormal blood vessels, they lose their structural integrity. These blood vessels are very friable and they bleed very easily. This can cause hemorrhage to occur within the eye, and what happens after that is that the retina gets pulled up. This is what we call retinal detachment. In early cases, a localized area of the retina is pulled up. In really severe cases, the entire retina is pulled up. This is called a total retinal detachment or stage 5 ROP. So, we also have an internationally well known classification of staging of ROP. Now, why this has been done? It has been done so that there is some sort of a uniformity when different people examine. We should have some sort of a level to base our signs on. So, we have 5 different stages for ROP, stage 1 being the most minimal and stage 5 being complete retinal detachment. So, in stage 1, what is, I would say, a very thin line, it is actually like a border between the area of retina which has blood supply and the area which does not have blood supply. So, you will have an area which is completely devoid of blood vessel and an area here, and there is a small line like a border, you see that, we call that demarcation line. We just saw about stage 1. Stage 2, this line becomes really thick and it is called a demarcation ridge. In stage 3, these blood vessels tend to grow over the ridge into a vertical configuration, and this is what is stage 3. And when it comes to stage 3, now this is the most important stage. Why? Because this is the stage where we actually try various treatment modalities. Now, I will get to how we treat ROP in a bit, but this is what is stage 3. This is where we can intervene and we can actually stop further progress of the disease. Stage 4 represents detachment of the retina in a localized area, and stage 5 represents total retinal detachment, which is really bad. It is very difficult to give any sort of useful vision once it goes to stage 4 and 5. So, the key here in ROP screening is to ensure that these babies who have stage 3 ROP do not go into stage 4 and stage 5. So, there are many ways to treat ROP. I think previously the most common way of treatment of ROP up to say the 1980s and 1990s was what we call cryotherapy, where we actually freeze a portion of the eye and help the ROP become less. Nowadays we give what is called laser. I think from the 1990s to 2015 or so, I think lasers have always been the gold standard. I think they still continue to be the gold standard for treatment. So, imagine giving lasers for these small babies. Now, these retinal lasers are well known to be painful. It is not a very nice thing to push the baby into undergoing, but the baby needs it. And from 2015 onwards, we now have a host of other injections that we can give into the eye, where without giving the baby any pain, without creating so many other issues, we can actually treat the ROP. So, this is something that is a lot more recent, and we do this also from time to time. Now, besides the stages and the zones that I mentioned, there is also something called plus disease, which basically means that within the stage itself, like in stage 2, you may have certain signs which tells us that it is easily going to go into stage 3 or it is going to actually get worse. So, this is what we call plus disease, and I do not want to get into the details of that because that is too technical, but basically plus disease means it is a possible thing that could worsen very quickly. Besides the usual classic ROP that we see, sometimes we get a very aggressive form of ROP. So, this aggressive form is very dangerous, and it is very often seen in babies around 30 weeks to 32 weeks, 28 to 32, let me put it that way. So, these babies can have a very bad ROP that is called APROP or acute posterior ROP, or what was previously called rush disease. So, this disease does not pass through all the various stages that I mentioned. They can from stage 1 suddenly skip and just become stage 5. So, identifying this is very tricky, because earlier I mentioned that blood vessels start to take off in a vertical manner. In this type of ROP, we will find abnormal blood vessels flat on the retina itself. So, sometimes it could be missed, and sometimes we would think that it is just an immature blood vessel. Well, in fact, it is something that requires very immediate treatment. So, there is so much within ROP, and what happens once we diagnose the babies have ROP. So, not all ROPs really need treatment. In my hands, about only 5 to 10% of babies screened require any form of ROP treatment, and my treatment rate is so low because number one, I do not wish to treat these babies just like that. I try to give the babies a fighting chance. I try to give these retinas a chance for spontaneous improvement, because very often even if it reaches stage 3 ROP, many times the ROP tends to settle down on its own. It may slowly become stage 2, stage 1 and then disappear entirely. So, this can happen very often, especially when it has already cleared the 60-70% mark, when it is crossing from zone 2 to zone 3. Very often we see a sudden worsening of the ROP, and then it starts to get better. So, it actually gives me some sort of thrill to see that the ROP, that is something that could be that is potentially so dangerous. When you see that it is getting better on its own, it sort of gives you some sort of happiness that nature is actually taking care of itself and the eye is healing on its own, and that gives me it's a privilege to actually look at that and see that in motion. But some of the babies are not that fortunate, and they need some form of treatment from my end. So, when I do laser, we usually use what is called a laser indirect ophthalmoscopy, which is a head mounted unit. So, the laser actually comes from something like a helmet, and this laser light is focused on the area of retina which is not which does not have blood vessels. So, when we do this, what happens is that the abnormal blood vessels start to shrink slowly and they disappear. So, this is one way of treating retinopathy of prematurity. The second way of treating retinopathy of prematurity is we give what is called anti-VEGF injections, and VEGF stands for vascular endothelial growth factor. So, now we have found out that there is this substance called VEGF, which is responsible for the growth of these abnormal blood vessels. Now, we have designed certain special molecules. I will just name one or two. It is ranibizumab or bevacizumab. These are all monoclonal antibodies or specialized proteins basically, and these are injected into the eye. So, when we inject an anti-VEGF, it interacts with the VEGF which is present within the eye, and the blood vessels, the abnormal blood vessels, shrink away almost instantly. Now, each procedure has its pros and cons. Now, the advantage of laser is that once we do laser, ROP is pretty much taken care of. We do not really have to worry so much about recurrence, because once we have done a good quality laser, we do not really have to worry about it. Even when we keep following up, even after laser is given, we follow up these babies. We want to make sure that the abnormal blood vessels are really shrinking away completely, and once it is shrunk completely, then our endpoint is reached. Then we no longer have to screen the babies further. However, very rarely even very good lasers can sometimes lead to progression of ROP, in which case we may have to continue to give an extra sitting of laser. Now, the only problem with laser is that it is a destructive procedure. So, when we coagulate the retina, that area of retina becomes a scar tissue and it loses its function. So, imagine if only 30% of the retina is developed, then we would be giving laser to the remaining 70% of the retina. And what that translates into is that the child for the entire lifetime will not have adequate side vision. So, the side vision is permanently compromised. So, this is one of the downsides of giving laser. However, it is very important that we understand that in order to protect the central vision, we have to sacrifice the side vision. So, and this continues to be the gold standard way of treatment. However, since 2012, with the development of all these new molecules, we have now been in a position to avoid doing this much of destruction. So, what actually happens here is when we inject this drug into the eye, the VEGF levels within the eye or the VEGF levels, they completely drop, and it gives chance for the normal blood vessels to once again start developing slowly. In most cases this happens without a hitch, and sometimes we may need to give a little bit of a peripheral laser just to cover the areas of retina which is not developed. So, this type of a laser is not going to be given extensively. So, because of that we can protect the child from having unwanted visual field loss or side vision loss. So, a lot has happened in the field of ROP, especially over the last 6-7 years. So, I myself, because I love doing this, I on a single day I visit about 10 to 12 hospitals and I screen these babies. So, these babies are kept for me on that single day. I would have 4 to 5 babies or sometimes even 10 babies in a single hospital, and all these babies the eyes are dilated and they go through the entire procedure. We actually put a clip so that the baby's eye is open, and we use a specialized a metallic structure that we call a depressor, where we actually press and move the eye in various directions, because baby being very small, baby will not understand if I ask the child to look to the right or to the left. So, I will need to move the eye to whichever side I want, so that I look at the inside structures a little better. So, ROP screening is that, and finally we take out the speculum and we put an antibiotic drop in the baby's eye to limit any form of infection or anything. So, it gives me a lot of satisfaction that we are treating all these 500, 600 gram babies. These babies are so tiny, they look so helpless, they are connected to so many different machines and tubes. It's really fascinating, and I am really passionate about treating these babies. So, I have been talking, I have been selfish and I have been talking purely about the ophthalmologist's role of ROP, but what we must understand is that with changes in technology, with IVF treatment and with lot of level 3 NICUs, it is not just it does not just come under my purview. It is actually a teamwork of the obstetrician, the neonatologist and the ophthalmologist, because we need to work together as a team to have a good communication, to know which babies need to be screened, which babies need not be screened, and convey to the patients. There are a lot of other support staff who are involved in this, because ROP screening programs, although it just sounds very simple, there is a lot that happens behind the scenes. The patients need to be informed, the patients, the kids, parents have to be informed to come at a certain time, the dilating drops has to be put. There is a lot of things that go behind the scenes to enable that there is a smooth transitioning of ROP screening. So, a shout out to all the obstetricians and pediatricians and especially neonatologists who actually have made ROP screening in all these places much more refined, much more streamlined, and because we are having this type of a proper ROP clinic or ROP screening done at so many places, none of the babies are missed. That is because we have such a good protocol. all the babies who need to be screened are screened. So, no baby is left out. Actually, I will have to give a shout out to even the government of India, because they have introduced what is called the RBSK program, and this program says that all babies, irrespective of whether they are preterm or full term, all babies need to get their eye examined, not just for ROP, but because of the various other conditions that I mentioned before. Did you know that babies can sometimes have what we call retinoblastoma or tumor within the eye? Tumors is something that we associate with old age, when we expect that, we think that it will occur only in older age groups, but this can occur even in very young age groups, and only when it is picked up early can it be managed better. And sometimes we can have, the mother may have some sort of infection when the child is within the womb. This can lead to problems within the child's eye. Child can have a retinal scar, a toxoplasmosis scar within the eye, which is basically something like a small parasite. And sometimes structures won't be properly developed, which could have been missed in the scans. So, these things are important to identify so that the parents can take the necessary precautions, come for the necessary follow up and get the necessary treatment for all of the other conditions. So, my dear friends, I hope you found this particular episode really informative, because many people do not know anything about ROP. They only know conjunctivitis, but ROP is something that, since I am passionate about, I thought you should know about ROP as well. I hope you found this educational and really informative. Thank you and have a wonderful day.